Thank you, Harry, and thank you to IPPR for producing this timely report. Timely because the foundational principles of the NHS are being contested like never before. We are living in volatile times. Old certainties are being challenged. Rights we thought secure are no longer guaranteed. Battles that were won must now be fought all over again. And that includes the very question of whether this country should have a national health service. We should be in no doubt, as Harry alluded to, that this is a fight that is brewing. And if it's a fight we have to have, then it's a fight that I am determined to win. 78 years on, memories are fading fast of life before the founding of the NHS. You'd have to be in your mid-80s or older to recall that time when wealth dictated health and illness threatened financial ruin as well as lives. Most of us can't remember, but we ought to listen to those who do. Because against the pervasive pessimism about our country's future, the questioning of whether we are capable of doing big things, and the cynical actors that are looking to exploit that mood, the NHS stands as a towering monument to the power of politics to change lives for the better. When the hospital almoner told Doris Herfling the suggested fee for the birth of her child, Doris had to haggle it down. She needed enough money left over to buy clothes for her baby. After the child was stillborn, the almoner said to Doris, "Now you haven't got a baby, perhaps you can afford to pay more." Things were far worse for those who couldn't get healthcare at all. Evelyn told the BBC in 2018 of the cobbler who would extract people's rotting teeth with the same unsterilised pincers he used to pull the nails out of shoes while old chaps sat around a bucket of blood watching for the entertainment. Families like Patricia Pascoe's tied around their necks a tarred rope, literally a rope dipped in the tar used on roads, to ward off whooping cough. And from the vantage point of a Salford corner shop, Robert Roberts saw how people self-diagnosed and self-medicated with quack cures because where he lived, more people were sued in the county court for non-payment of doctor's bills than for any other reason. Back in 1940, infectious diseases like polio, diphtheria and rubella ran rampant. It was against this backdrop, out of the rubble of war, that Clement Attlee and Aneurin Bevan set out to do the most civilised thing in the world, put the welfare of the sick in front of every other consideration. It was an act of courage as well as conviction. They stared down the Conservative establishment to build a national health service. The Conservatives in Parliament voted against the National Health Service Bill 22 times. The press characterised the move as part of a socialist tyranny. The BMA fought the Labour government every step of the way, not much change there then. In fact, a former chair of the British Medical Association described the proposed NHS as, and I quote, "the first step, and a big one, to National Socialism as practised in Germany." The post-war Labour government took on all of that opposition in a 3-year fight and won. In doing so, they took the shame out of need. In place of fear, they brought hope. They gifted Britain the peace of mind that the National Health Service would be there for us when we needed it. On the 4th of July, 1948, mothers were charged 1 and 6 for the delivery of their baby, enough at the time to feed the entire family for a day. On the 5th of July, Anira Thomas was born at 1 minute past midnight, and her parents weren't charged a penny. And since that moment, a consensus has existed. There have always been passionate arguments over the levels of funding and the management of the health service. But as governments went from left to right, across the spectrum, across the decades, we have been broadly united on the need for a national health service as a publicly funded, universal service free at the point of need. David Cameron, someone who knew firsthand the care and compassion of the NHS, paid tribute to what he called, and I quote, the precious principle we all hold dear and we all want to keep, of free healthcare for all who need it when they need it. Even Margaret Thatcher stood by, and I quote, the principle that adequate healthcare should be provided for all regardless of ability to pay. But as opposition parties lurch further and further to the right, that consensus is fraying. It is always when the NHS is at its weakest that the siren voices grow loudest. And so, having left the NHS in the worst crisis in its history, the right now argues that it's unaffordable and should be abandoned. Not just in certain sections of the media and right-wing think tank pamphlets. Former Health Secretary Sajid Javid now advocates a mixed economy of social and private insurance alongside state subsidy. Kemi Badenoch has called for, and I quote, a serious cross-party national conversation about ending the principle of free at the point of use, or at least she did before she became leader of the opposition. Since then, the Conservatives have announced just one health policy in 21 months, so not really much of a conversation starter. But it's not just them. When Nigel Farage announced his shadow cabinet, he forgot to appoint a shadow health secretary. Now, that might be because if Farage becomes Prime Minister, there will be no NHS. Farage has said, and I quote, we are going to have to move to an insurance-based system of healthcare. Just last year, he said, and I quote again, I do not want it funded through general taxation. It doesn't work. What will come in its place? Farage says he's, and again I quote, up for anything, and unusually I believe him. But during this election campaign, we haven't heard a peep about what reform plans for the health service. We know what they're up to. They're keeping their powder dry and counting on us to fail. They want to say that if a Labour government can't turn around the NHS, then it's time to do away with Labour and the NHS. So once again, it falls to Labour, not simply to rebuild the NHS, but to win the argument for the NHS all over again. Amidst the cynicism and pessimism, people will only believe that things can get better when they see it for themselves, and they are beginning to. The NHS is now turning that corner. Waiting lists are at the lowest level in 3 years. 4-hour waiting times in A&E this winter were the best for 4 years. Ambulances are arriving faster than for half a decade. Patient satisfaction with access to general practice has risen from 60% when Labour came to office to 77% today. Staff retention is the best we've seen at any point during the past decade outside of the pandemic. We've recruited 2,000 more GPs, and we're ending the 8 a.m. scramble with online appointment requests. We promised 8,500 new mental health workers over the entire Parliament. We've recruited 8,000 more already and rolled out mental health support to schools covering an extra 900,000 children. In the first 6 months of the last financial year, we delivered an extra 1.8 million dental appointments. And while we're doing all of that, the NHS is getting better bang for the taxpayer's buck, with productivity growing at 2.7%. We've achieved all of this at the same time as confronting record levels of demand and industrial action by resident doctors, and the NHS has done it all while living within its means. This is the first year in almost a decade where my department hasn't had to get the begging bowl out and ask the Chancellor for more in year. So change is starting, and it's starting to be felt. The latest patient satisfaction survey shows the biggest drop in dissatisfaction since 1998 and the first increase in satisfaction since before the pandemic. That is the difference a Labour government is making. We're showing that politics can change things, that voting does make a difference, that things can get better. But there is also a contradiction in these numbers. While patients themselves report services are improving and the NHS's data shows they are right, people are more fearful than ever about the future of the health service. Young people are increasingly voting with their feet. Last year, a survey found half of millennials are planning to use private healthcare in the next year. Employers are finding medical insurance an attractive incentive for young recruits. This presents an existential crisis for the NHS. If a generation of patients opts out, they'll eventually ask why they're paying so much in tax for a service they no longer use. This is the path to widening the health inequalities that we want to close, and it puts the future of the NHS itself at risk. So the case for the NHS needs to be remade and re-won, and the NHS itself needs to modernise so it meets the needs of modern society. The choice is not change versus the status quo. I have been more honest about the failures of the NHS than any of my predecessors. The truth is that the NHS has let patients down, and despite all the improvements we're making, it is still letting too many patients down. No one defends the status quo, not even its architects in the Conservative Party. So we need change. The choice is what kind of change we choose. Change the model of funding or change the model of care. Our approach is to invest in the NHS, to modernise it and transform the way it delivers healthcare. We're doing all of that while protecting its founding principles. Healthcare with Labour will always be free at the point of need, owned by us, funded by us, there for all of us. As a cancer survivor who owes his life to the NHS, this is personal, but my argument is heart and head. As the IPPR report finds, the NHS's problems would not be solved by moving to a different funding system. It blows out of the water the assumption on the right that an insurance model would be more efficient. Insurance-based systems spend far more on administration. In fact, if the NHS were to match the social insurance average, it would have to cut £7 billion from patient services to spend on bureaucracy, precisely the opposite direction of this government's approach. Today's report also shows insurance-based systems are more unequal. They put up barriers to healthcare for the poorest. Its supporters argue it prevents people seeking care unless it's really necessary, helping to keep costs down. Actually, it's a way to keep health down. When we need to catch illness earlier, to prevent greater costs later, an insurance system would keep people away for longer. Patients end up paying far more out of pocket or on top-up private insurance in social insurance system. That result is a baked-in two-tier healthcare system where the best care is reserved for those who can afford it, while everyone else is left with a poor service for poor people. It would return us to a time when your wealth decided your health. Labour believes that everyone deserves world-class public services, whether they come from my background or Nigel Farage's. And when we get the NHS right, that is what we achieve. By the end of the last Labour government, use of the private sector fell off a cliff because the NHS was so good, no one needed to pay. We've done it before, and we will do it again. The NHS model is the fairest way of funding healthcare. I believe that as a matter of principle, but IPPR underlines the pragmatic case too. And when you look at what's coming down the track, it is the model that gives us the best chance of seizing the opportunities of the future. As Nye Bevan said, the service must always be changing, improving. That's the principle at the heart of our 10-year plan for health. The burden of disease has shifted since 1948. The focus of NHS resources must shift too, from hospital to community. As the progress of the post-war society in nurturing a healthier population has begun to reverse, we must combat this decline with a shift from sickness to prevention. And as the burden on taxpayers grows, the imperative to shift to a productive digital service rather than a wasteful analogue service has never been greater. We have to go further too. The NHS must meet society's changing demands. As we become used to ease, choice and convenience at the touch of a button, young people especially want to experience the same service from their healthcare provider. Our modernisation of the NHS app will keep the NHS relevant for new generations of patients. And as the revolution in medical science and technology continue to unfold, we cannot allow the NHS to be left behind. Because the truth is this, the next 10 years won't just bring a decade's worth of change in healthcare, it will bring centuries worth. Healthcare is already becoming more predictive and preventative. Genomic testing will detect children's risk of disease from birth. Personalised vaccines are being developed that could cure cancer, the biggest killer we face. Will insurance companies agree to cover children born at high risk of disease? How will insurance-based systems avoid the grotesquely unequal prospect of chemotherapy for the socially insured and cancer vaccines for the privately insured? How can a fragmented system with multiple healthcare providers join up patients' data or rapidly adopt new technologies at scale? Attlee and Bevan could never have known it in 1948, but the model they chose has left the NHS uniquely prepared to seize the opportunities of this revolution so that they benefit the many, not just the privileged few. Today, as in 1948, it is by pooling our collective risk and resources that we guarantee the best possible healthcare for all. That's my position, that's this Labour government's position. So what is Nigel Farage's? Because in 3 weeks' time, more than 30 million people across Britain will be asked to choose their local and national leaders. Reform are leading in the opinion polls and have ambitions to take control of national government in Wales and even replace the Scottish Conservatives. So it's time they set out their plans and their policies for healthcare. Nigel Farage should stop hiding from his guilty little secret, be straight with the British people about what he actually believes and tell us what he would actually do. What kind of insurance system would he introduce? Social or private? On what terms? How much will patients pay in insurance premiums? What protections would be in place for the uninsured? Will the extra £7 billion administrative costs of the insurance system be paid for by cuts to patient services, higher taxes, or will it come from premium payers' pockets? How long would it take to replace the NHS with a new system? How much would that cost, and who will pay? Farage and his gang know what the National Health Service means to this country. It is no coincidence that the Vote Leave campaign plastered the NHS on the side of a bus because they knew how to tug at the nation's heartstrings. Now these same charlatans who sold us a pack of lies during the Brexit campaign are now hiding their true intentions for our National Health Service. If Reform want to form the next government, they need to come clean with the British public and answer those questions. But these are not simply questions for a general election in 3 years' time. They are hoping to be in government in Wales in 3 weeks' time. Wales has a special place in my heart. I'm a proud grandson of Wales on both sides of my family. Wales also has a special place as the birthplace of Bevan and the values of Tredegar that are written into the very foundations of Britain's National Health Service. The idea that the country that gave us Bevan and the NHS might now elect into government a party that would destroy the greatest legacy of that great country sends shivers down my spine. The fact that Farage thinks he can do so without coming clean on what he really believes on the NHS would be the biggest con since Brexit, arguably bigger, because at least he told us he believed in Brexit. You cannot trust this con artist with the NHS. The best way for people in Wales to stop reform and vote for the NHS is to back Welsh Labour. Look at what we're doing nationally. Labour is investing an extra £26 billion in the health service, funding every other party voted against. We are modernising the NHS to make it fit for the future. That is why waiting lists are falling, why patient satisfaction is rising, why ambulances are arriving faster, why productivity is recovering, why staff are staying. We are taking the NHS from the worst crisis in its history, getting it back on its feet, and making it fit for the future. So it is there for us when we need it, free at the point of use, publicly owned, publicly funded, so that whenever we fall ill, we never have to worry about the bill. Today, tomorrow, always, our message for May is clear. The NHS is on the road to recovery with Labour. Don't risk it with Farage and Reform. Thank you very much.
So, Wes, we're speaking now after yet another round of doctors' strikes. And this report suggests that NHS spending is overly skewed towards staffing rather than infrastructure, the cost of infrastructure. I wanted to ask, given that the NHS is effectively a single dominant employer, does that make it harder for governments to resist union pressure on pay? And what does that mean for your ability to invest in things like buildings and infrastructure and long-term reform?
So there are definitely choices and trade-offs. And if there's one thing I think the BMA are missing in their demands for even more than they've already had for resident doctors and even more than we've offered on the table, it is the total refusal to acknowledge those choices and trade-offs. You're right, they exist within the NHS. And I had this conversation just on the doorstep in my constituency yesterday, where I had a whole family of doctors and dentists, including a resident doctor, who had been on strike this week. And we were talking about the resident doctors' dispute, but we were also talking about the challenges right across the NHS. And to be honest, we were in kind of agreement about what needs to be done in the NHS and the systemic nature of the NHS crisis we inherited and the solutions to that crisis. The acknowledgement that you're not going to solve congested hospitals and without solving primary and community and social care, without the 3 shifts that we outline in our 10-year plan. So there's an agreement about all of those things, but there isn't an acknowledgement from the BMA that the £300 million they have just cost us this week with 6 days of strike action is money that would have gone into doctors' pockets with the deal on the table. But also, with the demands they would make of us in the future, this is money that could go on the technology and investment in the kit that they use, that they complain about, investment in the estates that they complain about, investment in the breakthrough medical science and technology, which everyone's crying out for because everyone wants to be at the top of their game. Everyone wants to be practicing the very best medicine. And it's that, I think, refusal to acknowledge that the government faces these trade-offs all the time. We've got £26 billion more for the NHS from the Chancellor. We've been the standout winner consistently across fiscal decisions that the Chancellor and the Prime Minister have made. But there's only so much you can do so quickly. So whether it's the 28.9% pay rise that resident doctors have already had, or the 4.9% average that was on the table with this deal, as well as the exam fees and the training places, I wasn't pretending that I'd solved all of resident doctors' gripes in 2 years, but I wish the BMA would stop pretending that we could. And I wish they would acknowledge that the way in which we're going to turn around the NHS, the pay and the conditions of the staff, the quality of care for patients, the quality of the states, the left shift we need out of hospitals community, we're going to do that over time. Surely, steadily, year-on-year improvement, and systematically. That's how we're going to turn it around. And I've sort of described the NHS sometimes as hanging by a thread and the resident doctors being, a risk of pulling it, and that's one of my fears. But in some ways, if I take a different analogy, it's a bit like we've turned the ship, the boat's going in the right direction, except some of the crew are trying to row in one direction while the rest of us are going in the other. You can't make progress that way. I mean, we are seeing an improving NHS, and we've seen improvement despite resident doctors' strikes. But the fact is, performance would have been better, and there would have been more money to invest in staff and services if the BMA hadn't been undertaking this strike action. So there needs to be a bit of compromise and give and take here.
But the logic of this report suggests that the balance has actually tipped too much towards pay at the sort of expense of other areas. I wanted to ask, do you agree with that? Do you think there has been sort of too much going on pay?
Well, there's no doubt that pay was eroded by our predecessors. I would just say to the BMA, there's a reason why they always try and benchmark back to 2008. What was going on in 2008? That's right, there was a Labour government that had been in for just over a decade. So, of course, they'd seen their pay and conditions rise over that time. But staffing is one component of the NHS's cost. And we do have to think about how we invest in the estate, in the science, in the service, in the treatment. Those are all things that matter, and the patient always has to come first. And just take you back to my family of doctors and dentists I met yesterday. Here's the other choice and trade-off. This country's paying quite a lot in tax at the moment. And we've asked a lot of this country as an incoming government to try and wipe the slate clean with the enormous black hole that was left in the public finances and to try and rebuild our public services. And I watched the same family recoil when I said, well, I'm sure you're not volunteering to pay more tax. And of course, they're not. So, we are absolutely committed to doctors, but they're not the only people who work in the NHS. I've got a responsibility to all 1.5 million people who work in the NHS, and the same number all over again who work in social care, many of whom are never paid as much as the lowest paid doctor. And while the NHS will always be Labour's #1 priority as a public service, it is not the only public service in this country. And when I tell my colleagues at Cabinet tomorrow morning that this round of strike action has cost £300 million, I mean, that's a lot of money, I think, in anyone's budget. It is a vast amount of money when I look at some of the budgets that many of my colleagues are spending on things that really matter to the public. And so we need this approach, this combative approach, to come to an end, and we need them to do a deal and to settle.
And just on resident doctors, before we move on to wider areas, can you give any kind of ballpark figure for what it would cost to pay the BMA what they want? And what would happen if that was rolled out across other staff areas, what that would kind of cost the country? So,
assuming we accept the sort of BMA's underlying assumptions about pay restoration, which I do not, but let me play with their figures for a moment, we'd be looking at £3 billion a year for full pay restoration for resident doctors. Not unreasonably, I think other staff would have something to say about that, i.e. we'd like some of that too. So then you're looking at £30 billion a year, and before you know it, just by doing that one thing, full pay restoration for NHS staff, which people would say, and I'm sure lots of people in the public would think, well, that probably sounds, they've had their pay eroded. We've just spent, just like that, more money than we spend on the entirety of the criminal justice system. So I really do think it's time for the BMA to get real. We are trying to turn this country around. There are signs of improvement, green shoots of recovery in the economy, which is why we are all absolutely focused on the economic impact of Iran, because it threatens all of that progress. Green shoots of recovery in the NHS and in other public services. But ultimately, we have to just remember what being part of a country is all about. Like we all have a stake in this. We all have to pull together as a country. And if everyone was demanding the same as resident doctors, and if if everyone was behaving the same way as resident doctors, we would be breaking this country. And I think it's time they got a bit of perspective, realised how differently they have been treated by a Labour government compared to our predecessors. They campaigned on jobs, they campaigned on pay. We addressed both of those issues in a deal. I do wish sometimes the BMA would take yes for an answer.
And actually, I just want to pick up, because there's another theme that came up in your speech about sort of generational attitudes, and in particular, younger people's attitudes towards private health. But and I will move on from resident doctors, but just a final one on that. I mean, do you think there is a generational shift here? We've had the members of the Residents' Doctors Committee yesterday saying it would be a waste of time to meet you and have pay talks. You know, what do you think is going on with the attitude?
Yeah, I mean, one of the wonders of social media is I sometimes get unfiltered, unvarnished feedback from members of the Resident Doctors Committee, which, to be honest, makes their officers look a bit stupid. Because the officers of the Resident Doctors Committee, who are much more accomplished as media performers and also have the virtue of being very nice people, will appear in the media and say reasonable things like, our door's always open. We really want to do a deal with this government. They just need to come back to the table with a better offer. Meanwhile, the actual decision makers, the people who are actually voting on the committee, are saying, I don't want to waste my meeting the health secretary is a waste of time. The Resident Doctors Committee of the BMA, these dozens of people who have held the NHS to ransom and just cost us £300 million, have refused point blank to meet me for the last 2 years. They are literally the only people I have asked to meet as Health Secretary who said no, and I'm beginning to take it personally. But you know, joking aside, I do take it seriously. This bunch of people have just cost the NHS £300 million. They are sending officers to negotiate with me who agreed a deal, I think in good faith, and agreed to recommend it to their committee. They go back. It's their committee that says no. I kind of need to understand the committee and their dynamics. And it's time for me to start talking to the decision makers, not just the interlocutors, to put it slightly more politely than I did on Radio 4 yesterday.
The report's clear that underinvestment in capital is holding the NHS back, but the capital budget is flat in real terms this Parliament. So I want to ask, if that doesn't change, where does money come from to modernise the estate and equipment? Or do we accept that we're locked into lower productivity?
Well, it's the biggest public investment in capital the NHS has ever had. There's a lot we can do with that public investment. But you are right to say, given the level of undercapitalisation, the state of the current NHS estate and the NHS estate we need to build in order to deliver on the shift, the money we've got from public sources is necessary, but it is not in itself sufficient. And that is why we are open to private investment too. Now, we have to tread extremely carefully here. I am, as many people here will know, extremely proud of the record of the last Labour government on a whole range of fronts, but I'm also not indifferent or blind to its failures and shortcomings. And the fact is that the way in which PFI, Private Finance Initiative contracts, were negotiated and then rolled out was not good for the NHS and caused higher costs than necessary and loads of aggravation on everything from changing a light bulb and basic maintenance to the albatross that lots of trust CFOs have felt around their necks. So we're not going to make that mistake again. But PFI isn't the only model of private investment. I mean, I look at what the Welsh Labour government has done with a mutual investment model, totally uncontroversial, leveraging private financing, and it's a big part, with as well as public investment, of Welsh Labour's plan, the £4 billion plan for their new hospital building programme, which is in their manifesto. So we're going to take a similar approach, learning from those models that work, and as well as learning from the things that, with humility, we did not get right when we were last in government and have no intention of repeating.
And I'll just ask a couple more, and then we'll come to the floor, so people are ready to be asking questions. One of the things going back to the report is that it finds high-performing systems invest heavily in primary, community, and social care. I think it's fair to say Britain is struggling on all three. Would you say is the failure to fix social care now the biggest structural reason that the NHS can't improve performance sufficiently?
It's part of it. There are some improvements I'm seeing in social care, and you know that's partly things that we've done as a government in policy terms. We're putting in over £4 billion over the course of the spending review into social care. biggest expansion of carers allowance since the 1970s. The disabled facilities grant increase has just meant thousands more home adaptations a year, which is brilliant in terms of secondary prevention and also helping people to be discharged safely back into home without risk of further falls and so on. But also just fundamentally it's dignity, it's independence, it's quality of life, it's giving people their homes back and being able to roam around their homes rather than being confined to the upstairs bedroom, as I've found far too many cases. But actually a lot of what's changing in terms of the NHS and social care are much stronger relationships operationally on the ground. I saw that this winter compared to last winter was my first as health secretary, and I'm seeing year-on-year improvement and identifying that. But of course there's much more we need to do on social care, which is where the Casey Commission comes in. But you're right, it's not just social care, it's primary and community as well, and that's why I say social care is part of it. We've got to tread carefully, and I think it's really important that people don't sort of flood to the barricades every time we're trying to change something for the better. So think about what we're trying to do with advice and guidance in general practice, for example. We can do a lot of admission avoidance, we can do a lot of stopping people from coming into A&E unnecessarily, and a lot more of getting people the right care in the right place at the right time if we've got better support for primary and community from secondary care. We're seeing that a bit with some of the work we're doing on corridor care in EDs, but also more generally, to avoid people ending up unnecessarily, and the word unnecessarily is the important word here, on an NHS waiting list. Now, there's a lot of concern about that and quite a bit of grumbling from general practice. Of course, we have to keep an eye and make sure it's working properly, that it's being used ethically, but the principle of right care, right place, right time is exactly where we need to be and is part of the left shift. Similarly, we did a big uplift in funding for general practice when we first came in. We want to continue to sustain increases in general practice funding. This is where sometimes I wish the BMA would kind of adopt a collective position on the NHS. It's the nature of the beast that they've got all of their different committees and they are part of the challenge in rowing in different directions. So on one hand, I've got big calls to invest more in hospital-based staff and services at the same time as I've got the GPC, I think quite rightly actually saying, but what about general practice? We want to do more left shift. So we've got to bear in mind some of those choices and trade-offs, but the fundamental thing we're trying to do is right care, right place, right time. That's often better for patients and better for taxpayers if it's primary and community, but we need to build that capacity and deliver that shift in a responsible and sustainable way.
Last one from me, and then we'll go to a round of questions from the media and then from from other stakeholders. Last thing I wanted to ask was, when I interviewed Jim Mackey last year, he suggested the NHS too often treats patients as an inconvenience, and that point absolutely struck a nerve with our readers. Do you recognise that culture, and what would you actually change in practical terms to make the system feel like it's built around patients rather than the other way around?
It is the irony of the NHS. There are loads of people in the NHS who work in it, do so because they believe in it and they are there fundamentally for patients. But there are times where, especially when the NHS is under pressure, and it is objectively under pressure, that people can lose sight of that. And it can be really basic things in terms of the interactions that staff have with patients and how they are seen and perceived. And sometimes that can be misconceptions on our part as patients as well. I'm doing a lot of work on maternity at the moment, and there was one case where the mum had an absolutely horrific experience. A member of staff had gone in to talk about it and to share what had gone wrong. And that member of staff then left. The patient felt that the member of staff had been quite cold and clinical and didn't care, even though something horrific had gone wrong. And the reason the member of staff had left at the point they did was because she'd left the room to burst into tears in the corridor, because she felt absolutely awful for this family and responsible. And so, the NHS is full of human beings, and we have feelings, we have frailties, and we have perfections and imperfections, and sometimes we can misread each other. So there's some of that. But I think ultimately the NHS is not one that has been built and designed around patients and ease and convenience. I mean, I got that a bit during the pandemic when I was going through my cancer treatment at that time, and I'd complimented the hospital on like how great it was that they'd got my pre-op assessments and given me my pre-op drinks and done loads of tests all in one morning. And I was like, this is so amazing. Like, I just didn't expect the NHS to think about my convenience. And they went, oh, actually, I'd love to tell you that's true, but it's infection control. We're trying to minimise number of trips to the hospital because of COVID. And I thought, well, if we could do it for that reason, very good reason, by the way, could we maybe just think about patient convenience and the number of visits they have to do and the frictional costs of the transport, the car park, the time off work. So I think Jim is right. It can be, some of these messages can be hard for the service to hear because there are a lot of people working in the NHS at the moment who are giving it their all and feeling enormous moral injury about the fact the NHS isn't always there for people when they need it in the way that they need it. So we always have to be, you know, a bit sensitive around some of the things we say, which obviously I'm famous for. But I think Jim is absolutely right, and we do have to tell the truth, and we have to be honest with ourselves about where the service falls short.
Great, and we will go to questions from the floor, starting with questions from the media. So we'll just have a round of questions from media, and then we'll go wider. If I take the lady with the hand up.
I'd say a couple of things. Let me take the last one first, and then come back to my territory. Look, the greatest betrayal on Brexit were the lies that were told to people about all of the benefits we would enjoy and have not materialised objectively. I have total respect for people who voted to leave the European Union. We had an honest and principled disagreement, and people turned out to vote in their masses, many people voting for the first time in their lives or for the first time in years because they were actually being asked their opinion. And that's why Labour respected the referendum result and why we came into government, not upending that. I think people do expect us to make it work, and I think people expect us to reduce some of the frictional costs, particularly on the economy, because it does tie into your first question, actually. As a country, we have to be honest with ourselves and with each other about the choices and trade-offs we face all the time. I understand a big part of the Brexit argument was about sovereignty and national determination. And I know that there were lots of people, because I think sometimes people on the Remain side made the mistake of not respecting the voters or thinking they had been duped. Actually, there are loads of people who voted to leave the European Union who did so, saying, I've heard your warnings about the economy, I think it's a price worth paying. I wonder how many of us feel that now. And when you've got big pressures to increase defence spending, NHS spending, schools, prisons overflowing, and when you've got the tax burden as high as it already is, and we want to bring that tax burden down, not put it up, we've got to go for growth. And the European Union is our nearest and largest trading partner. So we should be seeking to do more business with them, and in a pragmatic way to reduce the frictional costs of trade and doing business. I think that is sensible. It will help us in the NHS and across the rest of the economy, and it will help people in their pockets when they desperately need it. And that brings me on to the NHS. So look, I'm not complaining about the allocation the Chancellor's given us, not least as I'm seeing her tomorrow morning and I value my kneecaps. But I also accept the Chancellor's doing everything that she can with the choices and trade-offs that she's facing. So I have a responsibility to live within my means with the health and social care budget, to make sure we're spending it as effectively and efficiently as possible, and to recognise that as much as the NHS will always be the priority of this Labour government, we're not the only thing that matters, and I've got a responsibility to my colleagues around the cabinet table to make sure we're spending wisely. And that's where on capital, again, this is choices and trade-offs territory. I know there are people who rail against any private investment in the capital estate, but do we want an NHS that has safe facilities and more neighbourhood health services? Or do we want to live with the consequences of a broken NHS, with people being treated in substandard places and having to travel much further for care? So we'll do it carefully, with all of the caveats I said earlier, and learning the lessons and the mistakes of PFI, but we have to have public and private investment working together to invest in the NHS estate to make sure that it's fit for today and fit for the future.
We'll do a quick fire round of media questions. Yeah, we'll keep them short. I'll take two. Yeah, I'll take these two, and then we'll do a round from the floor, and then Harry will wrap up. Dave West, stage two.
Thanks. So, quick fire version. The federated data platform and the role of Palantir in it. I guess it's an attempt to leverage the single payer NHS, but there's running into lots of ethical, cost, implementation problems, like people in the NHS not seeming to feel it's really useful. Should the NHS be accelerating and pressing on with implementing the Palantir FDP, or are you thinking of triggering the break clause as has been reported?
I'm not a fan of the politics of the people who run Palantir, and some of the things that they have said over in the States are pretty abominable, in my opinion. But the federated data platform and the principle that underpins it of better joining up our services, making sure that patient records are joined up from one provider to another, using the single payer system that we have in the NHS, like that whole National Health Service model, to run more effectively, more efficiently, to identify patterns in data that might suggest higher risk more early, and all of the potential that comes with that data is absolutely critical to the future of the NHS. And there aren't many platforms and providers in the world who can do this. For me, the important principles are: is our data being held securely? Is it being used ethically? This data is owned by us. It is our data as patients and the NHS. It is not owned by Palantir. They are not allowed to use it contractually for any other purposes except for its use within the NHS data platform. And that gives me the confidence of knowing that it is held securely and used ethically, and that's the essential thing here. In terms of the longer term future, these are always commercial decisions that are considered in that way.
Okay, one more media one, and then we'll just do a round of take three questions at one time before we wrap up. So just the lady here.
Zoe Crowther from Politics Home. This report found that a fundamental restructure of the funding of the NHS would be a distraction. A lot of people have said the same thing of the abolition of NHS England. What would you say to those critics who say it's just been a job-cutting exercise? And what positive impacts will that big change have for patients by the end of this Parliament?
Thank you. So I know it's hard on people who work in ICBs, and it's hard on people who work in NHS England, and that doesn't, I don't treat that lightly or carelessly. But against the context of the conversation we've been having about the pressures on frontline services, the need to invest in the things that will transform patient care, it is simply unjustifiable to have two head offices duplicating to the extent that they do. And ICBs will take on a more focused role as strategic commissioners of health, and I think that will both improve the quality, speed and effectiveness in decision making, but it's also freeing up £1 billion a year to put back into the front line. I have to say, I think we're doing the right thing for the right reason, and in process terms, I don't see how else we could have gone about this, because there wasn't a way of engaging with the workforce of that size in a way that I wouldn't have been reading about it in the HSJ the moment a submission came up to me to even consider the concept. So I think it was right the Prime Minister and I kept it quite close with NHS leaders, and the Prime Minister announced it. But I have to say, I can understand why so many of my predecessors didn't bother and just sat there with a totally unsatisfactory bureaucracy and loads of waste and duplication. The level of opposition that you get when you try and do things like this is astonishing, and the weight and volume of vested interests is just extraordinary. And I'm afraid this is why you do need strong political leadership. I'm not interested as a politician in meddling in clinical decisions. And there's a reason we've got great clinicians and great scientists. It's my job actually to protect them from interference and being politicised. But my goodness, the idea that we would have over £200 billion going into this thing, a budget the size of the entire government of Portugal, and the democratically elected politicians shouldn't keep an eye on how that money is spent and to make sure it's used effectively, is kind of, for the birds. And there are so many professional vested interests, with a quiet, easy life, who will always oppose these big changes. And I think ultimately we'll have done the right thing, and the benefit will be to frontline patient services.
And then if we can take a final 3 questions. I know there's been a few hands that we'll take the 2 gentlemen in the front who've been very patient, and the lady in white.
Cool.
If you could just do all the questions, and then Wes will cover it all.
Thank you so much, Secretary of State. I'm Eric Salem, Director of Policy and Engagement at GSK UK. Just going very briefly back to you, when you first came into office, you said, health is wealth. My department is a growth department, which was, great words to hear. But I just wanted to just check. So the body of evidence has been growing on, the macroeconomic case for prevention, for population health, and ultimately it can keep people out of hospitals, keep people in work, economic productivity, growth, and so on. But that has to be an issue sort of that goes beyond just NHS responsibility and budget. So I'd really welcome your thoughts as to how we can anchor that more broadly across government to sort of support the NHS, but not just be an NHS problem.
And I'm Ben Richardson, Managing Partner of Carnot Farr, and we would positively note the report and your reaction to it, completely endorse the findings as being fact-based, and applaud in particular the call for higher spending in primary care, community care, social care. Those are areas we've published on. There's a strong return on investment for. Overall, it's a 4 times return on investment, but there's massive variation from less than 1 time to more than 8 times. And so just a question for you about what your thoughts are and how you increase funding but also manage to ensure a strong return on investment from that.
Yeah, and one more from the lady back there.
Hi, I'm Jemima Olhavsky from mental health charity Mind. Thanks to IPPR and for your speech, Wes. You spoke about a couple of themes around AI and tech transforming care, but also the risk that people seeking private provision undermines the legitimacy and support for the NHS. And something that we're seeing around mental health, where there are very long waiting lists, is people turning to AI and online for provision while they're waiting, and increasingly people receiving dangerous, harmful advice or forming harmful pseudo-relationships. So wanted to know what your thoughts are about how we harness the power of AI to make sure we have provision that helps, not hinders mental health, but also how we can replicate the success that you've had in physical waiting lists around mental health so people aren't feeling that pressure to choose. Thanks.
Yeah, those are 3 great questions. Firstly, let me just turn to medicines and life sciences. The truth is, in the last just under 2 years that I've been in this office now, far too much time and oxygen has been taken up trying to resolve VPAG. And then we had the added joy of the US deal and satisfying President Trump with his totally legitimate domestic ambitions that were not uncomplicated for the rest of us. And it was quite a unique experience being involved in a negotiation with our nearest and our closest allies in the United States at the same time as they were negotiating with your industry. We were negotiating with your industry. You were all negotiating with each other, and no wonder it took so long. But now that those issues are resolved, I think we've got a real opportunity to really focus on the core proposition, which is how do we make sure that with the single payer system that we have and the brilliant science that we do in this country, how do we make sure that we are both the home of new medicines, new medical technology and innovation, not just in design, but also in rollout as well and adoption. And some of the parliamentary debate has frustrated me a little around the US deal because it falls into the trap of viewing medicines as some sort of like dead weight cost, as if spending more on medicines is inevitably a bad thing and we shouldn't be doing that. We want to make sure we get good value for money for medicine, and as much as NICE drives lots of people potty, it's done a really great job and has been one of the success stories of the last Labour government. We've got to make sure that we are encouraging access to innovative and novel medicines and medical technology. I don't want British patients to be left further back in the queue, and I come across evidence and examples where that's the case with certain drugs, and we want to try and resolve that. But I think there's a lot we can do together in partnership with industry, which, as you said, is good for health of the nation, but also good for the wealth of the nation as well. And life science is a crucial sector for our economy. I know the Prime Minister recognises that, the Chancellor recognises that. Between them and myself, Liz Kendall and Peter Kyle, you've got a whole group of champions around the cabinet table for life sciences. So I think we've got an opportunity to move forward positively with the life sciences sector on both drug discovery, innovation, but also adoption and rollout, and making sure the NHS is a good partner as well as a good customer. Which brings me to the second question on return on investment. So proud though I am of the progress we're making in the NHS. I think it's fair to say that some exceptional and outstanding performance among some trusts is masking underperformance elsewhere. That's true on the money, but it's also true on patient services and outcomes. So one of the things that I'll be casting my BDI on over the course of the next couple of years is making sure that we start to significantly reduce the gap between the highest and lowest performers, and closing that gap by raising the floor, I should say, in performance rather than having a lower ceiling. We want to take the best to the rest. And I can understand why, as I've been saying, and so don't shy away from going to parts of the country where waiting lists aren't falling in the way they are in others, and pointing to it and acknowledging it, because I want voters and patients in those areas to know that, firstly, I've noticed, secondly, I care, and thirdly, I'm not going to be shy about it and acknowledge that there's a challenge. And so me being on national television, as I was yesterday, saying NHS waiting lists are falling is lovely if you live in a trust where your waiting lists are falling, your waiting times are shorter. But if you're not in one of those areas, you're not, okay, you might think, well, that's nice for them, but actually you think, well, what about us? So we've got to make sure there's consistency of improvement, and that's going to be a big focus. Which brings me on to Jemima's challenge as well around mental health, where I think that's true overall of NHS performance and improvement. We need to make sure that we have that focus on reducing mental health weights, not just physical health weights. And actually, this issue of technology is both cure and curse, I think, on the mental health front. There are so many great tools that can help us, whether that's someone who's waiting for some sort of treatment or intervention, or someone who might be able to access treatment more effectively if there's capacity in one part of the country and you can have an online consultation, for example. That might be part of the answer. but similarly, there's lots of bad advice, bad actors, and a lot of risk online as well, and a lot of drivers of mental ill health online as well. With the NHS app, as it evolves, we'll have the health store that will have NHS kind of approved and clinically validated applications. I think that will make a really big difference in the mental health space. But I have been challenging the team in terms of thinking about the improvement in the app and some of the opportunities, making sure that mental health is one of those early indications where we want to see progress. Would love to work with Mind on that. And while we're building that, I think we should also be proactively signposting to trusted providers like Mind, so that if people are in need of support and help and advice, rather than browsing the internet and relying on push notifications from dodgy providers, if you're on a trusted platform like Mind and you're looking at your website, well, you're more likely to receive high quality support.
Thanks, Wes, and I'll hand over to Harry to wrap up. Thank you.
Well, I hope you all agree that today's event has been a really interesting, enlightening conversation. Please do read the report to get all of the detail. As always, Wes has been very punchy on the panel, so I just want to be clear that IPR is independent. We have no view on which political parties you should vote for at the elections. We'll leave that to the politicians and, of course, the voters. What we are not agnostic to is the future of policy. We want a fairer, more prosperous and healthier society. And I hope the evidence in today's report really helps set out what the challenges are ahead and what the policy prescriptions we should be looking at are, and primarily the need for the government to go further and faster on the reform agenda that will deliver better health for all of us. So please do take a look at the report, because the stakes are really high and we need to get this right going forward. All that leaves me to say is thanks so much to Wes, to Secretary of State, to Laura for chairing, and to the IPR team for organising today's event. Thank you very much.